Thanks, everybody. I want this to be very informal. You can stop me anytime. I originally put this together for a different purpose, actually. So some of it is more hospitalist-oriented, physician-oriented, but I think almost everything is generalizable to anybody working in healthcare, or for that matter, in almost anything. So I was asked to put together an article about for a series that the Society of Hospital Medicine called the Legacy Series, and it was asking us to reflect on our career and try to share some of the things that we thought were helpful for us to further our career and have a good career in the field. So that was sort of the nidus of this. Obviously, this was made for an outside audience. You know about Sacramento, probably. So it's divided up into two parts. One part might be boring for those of you here at UC Davis Health, maybe not, I don't know. But part of it is to say what a chief quality officer is and what I've seen happen here in the last 4 years, because I think it reflects more on how I got to be where I'm at now. So, you know, UC Davis is a big place. We're at 100% capacity virtually every morning with 650 beds. A very busy ED, a major trauma center, lots of faculty, residents, and staff. And we are recognized as being a good hospital by several of these different organizations, including Most Wired and U.S. News and World Report rankings and so on. Magnet. We have a children's hospital embedded in the hospital, and they also get good awards. This here is for our ELSO program, or ECMO program, if you will, which is for both adults and peds. It's a very advanced program. So it's been my privilege to work here for the last 4+ years. I got here, I think, on February 1st or so, so just over 4 years ago. And they did not have a chief quality officer, so I was walking into a brand new position. And this was not exactly how they had the job description written up, but this is my aspirational job description. It's to save lives and improve the quality, safety, and efficiency of care, not by my personal superpowers as a healing physician, but really by helping our staff do the best job they can do, by helping set priorities and goals, improving communication and culture. And I will be talking quite a bit about that culture piece because that's been transformational, I think. Using data and getting that data to where it's needed. We were in bad shape, I think behind the curve 4 or 5 years ago, and we've come a long way there. Still a long way to go, but much better. And building infrastructure. People need infrastructure to do their jobs well. So to empower and enable engaged staff and patients, and to mentor junior leaders. And to really help the staff in as many ways as possible, because they're doing a hard job. We all know about physician burnout, what a problem that could be for us. And it's not just physicians, it can be nurses and other staff who are faced with the ever-changing environment in healthcare with long hours, stressful situations, overcrowded facilities, EMR that causes people to kill themselves, and sometimes literally, and you know, things like that. So we need to do all we can to make their lives better and make their workflows easier. So how do we set these priorities? Well, it's not easy because we have to review reams and reams of data that come in from all different sources. Vizient is where we upload our data, formerly known as University Health System Consortium. Pretty much all the academic medical centers upload their data there. It's all administrative data. Now they're starting to add some lab data. But importantly for us, it is risk adjusted. So they provide us with some benchmarking and some comparators so we know where we stand compared to the other academic medical centers with at least a good faith attempt to do risk adjustment, which isn't always perfect, of course, but we pay a lot of attention to it. We get CMS data. We have this leapfrog survey we always fill out that goes in. We have increasingly insurance companies come to us with their own scorecards of our work and say, you won't be a preferred provider unless you do X, Y, and Z. So we get this data from all over the place, and the data time periods do not always line up. In fact, they almost never do. So when you get a CMS scorecard, you're usually getting a rolling 3-year report from something, the newest is usually 2 years old. And you're often looking at going, come on, man, that's like old news. But it affects today's pocketbook because that's the way that system works with the hack reduction programs and the emission reduction programs, et cetera. So because you can't measure everything and because you can't focus on everything, you have to decide, what are we going to focus on that will provide the biggest bang for the buck? Are we ready to make a big change in this area? Are we ready to focus on it with our energies and add resources if needed? How heavy is the lift? And usually you're trying to find something where, yes, you can do this. It's fairly easy to do. It's low-hanging fruit, and it will have a big impact. That's the sweet spot. It will improve value. It will reduce costs. It will improve safety and efficiency. If you find that one, go do that one first. Sometimes you need to go to the next level, something that needs more resource that's not easy, but you just have to get there. So you always have to do this. And this discussion's ongoing. It's ongoing every week, every month in our meetings, and things bubble up from our frontline staff all the time. And we have other parties that are sort of handed to us. We have outside programs like Prime and QIP. Those are big Medi-Cal waiver programs that basically give us a set of measures to accomplish, and sometimes they have big bucks attached to them, like $500,000 per measure. But how many measures in Prime now?
58.
It's big, and luckily, most time those measures line up with where we want to go anyway, and most time they actually help us by getting more buy-in from the C-suite that's where we need to go and we need to invest in this. So luckily, most of the time it helps me as a quality officer convince other people in the C-suite that that's where we need to go. All right, so a little bit of this. So how do you set priorities? Sometimes it's based on what keeps you up at night. So if you go around and ask doctors and nurses, what's the last what's the last thing you remember that hurt a patient of yours, and what do you worry about? What do you think the next thing will be that might hurt them or cause disruption in our system, or cause a suboptimal outcome? So what are some of the things that you guys think about that bother you? Staffing.
Like having available staff, hiring up, recruiting.
Hospitalists are always complaining. I know, because I am one.
The wrong dose of a medication given?
Medication errors, absolutely, always up there. Adverse drug events. Top 3 adverse drug events. What are the drugs associated with the top 3? Insulin, opioids, anticoagulants. Top 3 in almost every hospital. What else? What keeps you awake at night? Infections. Burn you, be worried about hospital-acquired infections.
M.H.M. CI.
Yep. What else?
Wrong patient or wrong site.
Wrong site stuff.
Before and after.
Yeah, reportable events. Surgical safety. What do you think is at the root of most problems in the hospital and healthcare?
Lack of communication.
There you go. Teamwork, communication, coordination of care. Those are big things. Lack of data. So anyway, every year there are organizations that come up with what their top 10 things are in quality and safety, but these are sort of some of the things that keep me awake. They actually don't keep me awake anymore. I'm a pretty good sleeper, but still, they worry me during the daytime hours. Culture and communication, very big. There is no protocol that can fix a bad culture. There's no order set that can fix a bad. There's no EMR that can fix a bad culture. And this communication, we need communication constantly, constantly. It is so important. It is so hard to do reliably across all the spectrum of care. Very difficult. Infections, we mentioned that. I think mental health is one of our biggest problems in this county, for sure. And it is stuffing our hospital full of people who don't actually need to be here for medical issues. They're here for mental health, behavioral health, and those sorts of issues. And now it's really impacting. Every day we're reading incident reports about threats to staff. So we've had to do a lot of training around how to handle that and how to avoid that. We mentioned the high-risk adverse drug events. We mentioned data. I think transitions of care is a big worry in every hospital, in part because of all the communication and coordination that is inherently needed in those things, along with the readmissions. And then the EMR is a big worry for everybody. It's a great tool, but it's also a source of great frustration, and no one's happy with their EMR. We have Epic, and as Bob Walker would always say, Epic, it's the best there is. It's the cream of the crap. None of them are really built around what the healthcare team needs. And if you try to find a place where there's a central hub of coordination and communication where all the different disciplines would document something together, it's almost non-existent. It's very hard to do. So there's a lot of issues with that. Lab imaging and follow-up, and I would say in other words, a test is ordered, the person who orders it, might get the result, but maybe it was a specialist, and there's something in the lung when the gastroenterologist ordered the test, and they think, well, that's not my problem. I'm a gastroenterologist. That sort of issue, the follow-up of abnormal tests, and delays in care or diagnosis that can happen from that. Patient experience, I think, is a real issue. It's not just a fluffy issue. Patient experience is related to patient outcomes, more so for some of the HCAHPS questions and others. In particular, the transitions of care HCAHPS questions are very directly linked to outcomes and well-done trials. And throughput. We have, like I said, we have an incredibly full hospital every day. We're opening beds where there shouldn't be beds. We have, don't tell anybody that. We have all these issues, and we are concentrating on ways to move people through the system and be more efficient every day. And the more full you get, the harder it is to be efficient, right? It's like one of those, puzzles where you're moving the pieces around, and if you've only got one tile or no tiles left, you can't really be very efficient. So you'll be hearing about some of that. So I talked about infrastructure. I think that's really most of what I did my first 3 years. Was we were building up basic infrastructure to help us do stuff that we couldn't do well before because we didn't have data where people needed the data. We had a fairly legendary CIO who was like the meanest librarian who didn't want anybody to have his books, right? Well, he's gone now. We have a different CIO and now we have a chief medical information officer whose main job is to make sure the EMR works well for the customers. And that wasn't here before. We have lots and lots of live online dashboards that are available to the frontline staff. We have a lot of active surveillance sort of reports. We have Healthy Planet and Epic, which helps us a lot with the outpatient enterprise and just starting to tap into the potential of that. Ryan's been involved in a lot of this stuff, along with Slicer, Dicer, and new tools that are coming out that help us look in real time by tapping into registries, and people can do live queries and find out a lot of stuff in a hurry. So when I talk about infrastructure, I've hit on some of this, but I think it's also strategic leadership is basic infrastructure. The data governance, people have to agree on the definitions for length of stay in a different use case. You might have more than one definition, but people should know what those definitions are. For example, the ICU length of stay is usually measured from wheels in to wheels out, whereas, you know, length of stay on Vizient reports or hospital length of stay is calendar days, right? So yeah, you have to be defining these things, and it gets complicated. And we're really not that far advanced in this yet, as far as we should be. But there's some good work going on. Jason Adams, in particular, here is a pulmonary critical care doc, is coming up with some really great ways to do better data governance. That includes saving your code in terms of pseudocode, like English language code, that also translate then into SQL. And all these data definitions and all the methodology and all the vetting are all stored in a common place, a common tool called, I think, Calibri. Tell me if I got that name wrong. I think it's Calibri. Calibra. Thank you. And then measures, as I said, training and policies to reinforce culture and teamwork, and a framework and tools for quality improvement. And I'm going to talk some more about wellness and culture. So I was a little bit skeptical about, I mean, I knew culture was important. I was a little skeptical about tools I had heard others were using to build teamwork and culture. I was a little skeptical about daily huddles. I was a little skeptical about, you know, calling out praises every day and holding hands and, you know, come on, you gotta be kidding me. I wasn't quite that skeptical, but still. But I have to say, it has been absolutely incredible the speed with which some of those things have changed our culture here. And it's still ongoing, still transforming, but it has changed a lot. Also, there's been a few leadership changes. There's been some crusty old docs whose time it was to move on, who moved out, who made it easier to change culture. And, you know, some of those things evolve over time. But I think some of these tools have really been successful. This is an example of some of the dashboards we have. These are the ones from our group, Quality Initiatives and Reporting. You can go down to the individual unit level, the individual department level or division level or service level. In other words, we map to what our doctors and nurses think are important as categories. We get data from Vizient in terms of service lines, which is based on their diagnoses. But the doctors don't want to see that because some of those patients aren't their patients. They want to see it by their organizational strategy. So that's how we have arranged these. You can often get down into the individual patient level. Of course, you have to have different access for that. And I think the main thing about patient safety culture is people stop blaming each other. They stop saying, well, the ED did this to us, or the OR, or the hospitalist, what do I say, those damn orthopedists, or the ED, you know. So it's all about, instead of talking about us and them, it's about how do we approach these problems. And it's really all about that. And I remember talking with Tina here 3 years ago, and we wanted it, and she was particularly a good champion of this. She wanted just culture here, and so did I. But we weren't ready for it. And we were skeptical we would be ready for it. And now it's implemented and in place just a few years later with some of those changes I was just talking about. So really rapid. It's like we were trudging up the hill, you know, almost there. Oh, come on, this is so hard. And then all of a sudden it was like, just started to happen. And that's the way a lot of these things happen. You have to put in your dues. You have to build the infrastructure. You have to get the basic pieces in place. And you have to have the leadership that says, we're going to do this. If you have those things, you can do this. Part of this was these value team dyads. So we have nurse physician dyads on every major unit. They collaborate on quality and safety projects aligned with institutional goals. The idea is to improve communication between nurses and doctors and to leverage each unit's work so it can spread more rapidly to the other units in the system. And identify and spread things like team deviance. And this is an example that Hershaw Joel brought, I think, into the equation, this idea of positive deviance. We're trying to find, we're trying to catch people doing something good, where it's usually hard to do something good, these 5Ds, and then spread that amongst the units as fast as we can. So one of these examples was one of the floors had a nursing physician dialogue about when the nurses made pages to the doctors and what was the right etiquette on each side of that equation, when they should or should not page something, and if they could group pages for certain things. And they were successful in doing that on one unit. That was spread, that concept was spread to several other units with good success. And then just scripted ways to talk to each other to keep things professional and stop calling people names and getting mad at them and just writing them up. You know, instead of that, you're having more direct conversations using scripted language. In this case, if you have something where you think might hurt the patient, you don't allow that to happen. You go through this scripted language, and everybody on both sides knows once they pull the safety card, things got to stop. You have to have some mediation, right? And SBAR, again, just another example of structured communication I think can help. These are some pictures of our tiered escalation huddles. Lynn, maybe you can say a few words about huddles and what you think.
Yeah, so I was with you. I wasn't so enthused about the, you know, the starting out a morning huddle with finding something that somebody did good. As a manager, I think I focus 99% of my time on problem solving. But I have to say, it's really transformed the culture of the burn center. So we start out every morning in nursing right after a group report, or a group report on all the patients before the nurses go out onto the unit, before they set foot on the unit. We go over who did what that was good on the previous shift. We recognized and set that positive tone for the day and say, hey, it's going to be a good day. We go over things that are potentially issues, whether it's being short on an IV catheter, or maybe part of the central plant's going to be down and affect the water pressure in our unit or something like that. And then right after that, we have an executive huddle where executives from the hospital come out to each and every unit. They scatter out in a shotgun approach and cover the whole unit in probably or the whole hospital in about a half an hour's worth of time. Catch anything that we need to escalate, and then they also give us things that they need us to know. It's so much faster actually than email, even though it's all manual. It's crazy, and I know, Christina, you come out and do a lot of those huddles with us. It's a phenomenal, very interactive approach. But what's nice is it actually makes that culture connect from the bedside nurse, just speaking from nursing, to the executives that run the hospital. So much communication goes back.
And the janitorials to EVS.
Yes.
I mean, they become part of the team and really feel it, and they see how it impacts us. And I can't tell you the number of times we're sitting at daily huddle. Somebody says, I've got a problem over here. Somebody else goes, I'll fix that. Let's fix today. Or they'll say, stay here right after the meeting. We'll touch base. We're going to work on this together. So instead of people blaming each other for something that's going wrong or saying nothing ever gets fixed, you know, that's what kills enthusiasm and engagement, is thinking that you can't do something about anything. In reality, you can. And so these are tiered huddles, as Lynn was describing, and things that can be fixed on a local level are things that are systems issues get escalated up, things that are having difficulty with get escalated up, and of course things go back down the other way too. So I think those huddles have been very important. So another piece of infrastructure. Sorry about that. A little bit. So we had some really good docs and nurses working on antimicrobial stewardship and infection prevention, but they were woefully underpowered and probably didn't feel empowered to make changes. So we looked at our hospital-acquired infections. We looked at our C. diff rate. Our C. diff rate was high. Our standardized infection ratio, if you know what that is, that's a number from the CDC that tells us that if 1 is as expected, 1.2 is 20% higher than expected. We were hovering around 1.2 all the time. And that's not uncommon in a major center which got burn trauma and all these other things, oncology center, BMT, because the risk adjustments aren't perfect, but nonetheless, we knew that we could do better than that. And we just didn't have the manpower to do it. So one of my first things that I focused on was this. We reformulated the infection prevention committee. We formed work groups and asked each one of these work groups and a task force to focus on HAI, either CAHL, CLABSI, sepsis, SSI, and importantly, one of the groups was focused on antimicrobial stewardship and infection prevention itself. What do you need? We asked them to do a root cause analysis, or excuse me, a gap analysis, looking at best practice, where we're at, where we should be at, what's needed to fill that gap, how hard that lift's going to be. And we applied for, I forget how many FTEs. It was a lot. We had new software for that integrated with Epic called Icon that helps us with the whole process of logging all these infections and getting them uploaded to NHSN. We brought on several new doctors and more infection preventionists, a lots of focus from work groups on working on these things and work to turn these things around. And they did a great job. It was really gratifying to watch all these things get better, just because we gave them the tools they needed to do the job. They always wanted to do the job. They just needed to focus on the tools to do the job. So, and for example, these are the SIRS. I was talking about standardized infection ratios. You can see some of these are getting down into 0.5 territory. And C. diff went from 1.2 something down to 0.6 or under for C. diff. So we basically halved the number of C. diff cases that we have in our hospital each year. That is a huge, huge issue. And it was very multifactorial. We even have a screening program where we're surveying for community carriers of C. diff when they come in and isolating them. Most hospitals don't do that. Something fairly new on the scene. And we change order sets, and we have handshake stewardship where the docs actually go on rounds with the different teams. It's not all the way built out yet on the adult side. On the ped side, it is all the way built out, and we're continuing to recruit for more of these folks. We mentioned opioids. We've had a big push across the whole spectrum of care, ED, outpatient, inpatient, to reduce opioids and to have alternative forms of therapy. And a lot of this was organic. That is, a lot of services were working on this before we ever worked on it. Others, Eddie Ibiso over here has acted as a big project help for Kathy Lammers and others in our institution to work on inpatient efforts, revamping all the order sets and the policies and protocols, and not only reducing the number of opioid doses given, but also improving the monitoring and the way that we look for those high-risk patients who go on opioids, try to reduce ADEs in those patients. So I can't tell you how much work has gone on this across the whole spectrum, but it's been a big, heavy lift. We had an underpowered, puny palliative care service that was struggling to stay afloat. I think to a large extent we fixed that. We have palliative care in-house 6 days a week now. We hope to go to 7 days a week soon. We have an outpatient palliative care program where they go, it's home-based palliative care. It's been very effective. And I think probably the biggest impact will come from embedding palliative care into the cancer center. So people will be automatically referred to palliative care when they reach a certain stage of disease. And that's huge. We had some resistant culture around this from some of our docs who thought that palliative care meant they couldn't continue to work with advanced randomized trials or so on. That's completely not true. So a lot of this was debunking this and working with those docs and establishing trust. And we've got some really great docs who are good at doing that. Jack McMillan and Nathan among them. And this is the home-based palliative care, how the effect it's having. Transitions of care. This is again, we didn't have any infrastructure on this when I got here. We didn't have a dedicated team working on transitions. So we established some basic infrastructure, starting to work on relationships with SNFs, starting to work on standardized risk assessment of patients, starting to work on post-discharge follow-up phone calls that were really meaningful and would triage them to help as opposed to being a PR phone call. And started to build, along with Matu Mola over here, helped us start a collaborative care model where we'd start to follow patients into SNFs, follow our own patients into SNFs, and as well as having, now we've got a couple, I'm not going to use the right term, I would call them navigators, but that's not the right term for this that she's using. I always forget. Coordinator. Care coordinator, who's basically following a lot of our patients, either by phone or by going out to see them, not to be their care provider, but just to make sure the communication's on board. We know when they're leaving, they've got the right med list and things like that. So those partnerships continue to grow. We have a great new transitions leader, Vanessa McElroy, RN case manager, and we're working to streamline prior auth by having people from health plans and medical groups in-house that we can call up and talk to right away. And in some cases, prior auth has gone from 3 days to 3 minutes. So that's huge when you got somebody in the ED, and you can get an ambulatory solution, but only if you get the authorization. Otherwise, they have to take up a hospital bed, right? Same thing on the back end. You've got patients who they could leave, but they could get more ambulatory authorization right away, or maybe they can get outpatient antibiotic therapy, or maybe they can go to our what we call the AIM clinic or wound care. But you have to get that authorization quickly, or else they're going to buy hospital days. So this has been really exciting to see. And now we're focusing on MVPs, not frequent flyers. MVPs, multi-visit patients. These have a specific definition. I refer you to the work by Amy Boutwell from, I think she's from Brigham, I forget exactly. But she wrote a nice toolkit that's on HRQ around how to work on transitions of care. I'd worked on previous transitions of care work with Project Boost, which we borrowed a lot of things from there as well. But this approach has helped us focus on certain things, including these MVPs. And here's why. So, here's why. This is the number of patients that are MVPs that have 4 or more admissions per year. That's percent. 3.4%. Only 3.4% of our patients have 4 or more visits in a year. But those 3.4% of patients cause 50% of our readmissions. So if you don't tackle those, you're not going to win, right? You've got to tackle those, even though those are the most difficult ones, because they often have bundled psychosocial, substance abuse, all kinds of issues like that. You've got to get down the weeds. We're starting to build these individualized care plans for them, an MVP care plan in one place so everybody knows where it is. And basically working to work with not only what we do with them, but what their outside care plan or their insurance plan, how they might be able to help us, how social service in the community might be able to help us. And if you can make an impact on just a few of these, you can make a big difference. So we're really trying to start to focus on this. And I'll call your attention over here. You can see the kind of filters we've got so we can dive into these patients on all of our scorecards. And we're starting to see this break now in readmission rates finally. After we did all this work on infrastructure for a long time, we're finally starting to see this. Now we have a full quarter's worth, and that's the lowest readmission rate for the full quarter. This isn't quite the full quarter, but it's still at that rate. It's the lowest readmission rate we've had in recorded history. So, and these are difficult patients, and it's hard to keep them out. Mortality. It's the biggest dot, right? You're supposed to move the dots. This is the biggest dot. So this is, again, observed to expected mortality, and you can see it's been improving steadily over time. One of these lines is adult, and the other is peds. They're both Some of this is by better documentation, right? You've got an observed to expected equation. If you document better, your expected mortality goes up. But some of it is also working on things that kill people, things like sepsis. So we've been putting a lot of work on sepsis. And we have the same similar curves on sepsis mortality. We could talk for days about sepsis and all the efforts there. Blood product utilization. This is one of those where you save money, you help the patient, it's better quality, it's better safety. So this is the percent of patients who have a hemoglobin less than 7 when they get their transfusion, right? So that goes up, those go down. We got terrific leaders in this realm. Sarah Barnhart is fairly junior, but she is a powerhouse and very well organized. We've been helping her since she was still in fellowship when she started work on this, and she's just been terrific at leading this. And we're now working on intraoperative transfusions where we found some opportunities as well. All right, so that was all now the more personal stuff. So how I got to be in this position. And people would ask me, how did you get into this job? What do I do to sort of end up there? And I would say, well, I don't know, it just kind of happened. I just did. Things just happened. I just followed what happened. I went from being a chief resident at Good Sam. I was speaking with Dr. Cheney before. He was at Good Sam and Phoenix with me at that time. I didn't know he was here until a few minutes ago, so it's a great network. And there my identity was largely as a clinician educator. And I was on faculty as an associate program director for the residency program. I was trying to, build my chops as a teacher, and that was sort of my identity. And as part of that, I was asked to go get some skills in research. And this is embarrassing how old I am. Okay, so I didn't have a type. I didn't have a computer. And they were putting me on a plane to go to Michigan from Phoenix every month to do SAS on mainframe computers. So my first introduction to research, the necessary bar I had to get over was I had to get Mavis Beacon teacher's typing on the computer first and learn how to type. And then I had to go, learn how to use the personal computer and stuff like that. So all while I was having a couple babies and raising kids and all that. So plus my wife. So I got some evidence-based medicine training. That became a big part of my identity as well. I went to a master's university where they teach a lot of this. They teach people how to teach evidence-based medicine. And if you've read some of that stuff, it means stuff like knowing the number needed to treat, the number needed to harm, doing a critical analysis of studies to see if they're really valid or not, things of that nature, to make better medical decisions, better policy decisions. Hospitals medicine became a thing. Article came out in the New England Journal, and we read it, and we went, gee, we're hospitalists. We didn't know that. The term was coined while we were, doing it. How many hospitalists in the country now?
Thousands.
40,000? Maybe 24,000 members in Society of Hospital Medicine now. And so that's the most rapid growing field in medicine, and I happen to be part of it. And the quality and safety movement started to happen a lot around the same time. So I got interested in teaching people around how to do that, and then I started to learn quality improvement skills, just things I picked up, and then some formal training that I availed myself at. I left Good Sam Banner in 2003 to become a division chief hospital medicine at UC San Diego in 2003. They had 3 hospitalists, so I wasn't the division chief right away because there was no division. There were a few guys. But we built that up rapidly. I think we had 3 people when I arrived and 53 people when I left in 2015. So I was there for 12 years. And while I was there, I also obtained some grants and wrote some improvement guides that went to HRQ, Society of Hospital Medicine, and other places. We started to do collaboratives across more than one site after we published some successful results from UC San Diego. And that led to some visibility with the Society of Hospital Medicine, the professional society, that hired me part-time to be their chief medical officer sort of equivalent to help run some of these collaboratives. So pretty soon I was working with hospitals from all over the country, in some cases across the globe, to work on things like transitions, opioids, drug safety, transitions, VTE prevention, insulin management. And as I did that, I got to know tons of experts in those fields. And, you know, I'm not an endocrinologist. I wasn't a diabetes expert, but I knew how to implement things. I wasn't a clot expert like Rich White, but I knew how to implement things. I wasn't necessarily a pharmacist. I didn't know pharmacodynamics other than, you know, the very basics. But working with all those people, you realize they're so smart, they don't know how to standardize the stuff. They're thinking about the minutia, right? And I always have to crowd them towards, you have to make it good enough for the 80% of people, and we'll handle the 20% in other ways, right? You can't make it so complicated that you can't standardize it for the masses. So learned a lot about on the ground learning and learning from other sites constantly about how they did stuff. And then chief quality officer was out to come here, and you know, of course, I tell these residents or whatever that, yeah, I just got lucky. I don't know, so they were very, very thankful for that. You know, it's not useful advice to say you should just be lucky, right? I started to realize that more, and I started to be a little more thoughtful about, you know, what they could do. They were asking, what should I do? How am I going to be successful in this environment where things are constantly changing? And how do I position myself for success? Because this change that's happening is only going to accelerate. So I developed some bullet points for that article I was talking about in the Legacy series. And first lesson, learn how your hospital system works. Know the organizational and committee structure. Know where to go with new ideas. If you don't know, ask somebody who does know. The committees, like chief quality officer maybe. And know what the institutional goals and priorities are, because it's a lot easier with the wind at your back than to come up with one other thing that you want the administration to support, right? You don't have to know all the politics, but you have to know that there are politics, and find somebody who knows how to avoid the landmines. And then join something you find interesting. Be careful what you pick, because issues usually don't go away. If you pick transitions of care is going to be a problem for as long as your career lasts. If you pick, you know, safety and for insulin use or drugs in the hospital, it's not going to go away. And you can make it better, but you could be on that project for a long time, right? It's not a project, they're usually programs. So find something you really like. Start small. You know, improve your own care, improve your own practice, improve your own little group's practice. On the other hand, think big. Prove you can do things on a small scale, but think about spread and sustainability. Think about if you could magnify the results of your success. You know, think about how you would do that. Think about the impact of that. Maybe even not just across one hospital or one unit, maybe across 30 hospitals, right? Why not? Think about it. How would you do that? Now we've got some hospitals. I was working with Dignity Health on stuff, and Sutter for that matter, on glycemic control. They had a more centralized, you know, computer environment. So if you change the EHR centrally, you change order sets in 20 hospitals at once, 30 hospitals at once. UC doesn't work that way. that smart. We think we're too good, so we have to have 5 separate builds of the EHR and 5 different systems. Anyway, think about things like that, and then think about things like collaborative and research experience. In other words, do your quality improvement well enough that you can publish it. And it will not only ensure that your quality improvement will be more successful because you're writing things out and you're thinking things through, but it will also help spread things, and people will start calling you to say, gee, that was cool, can you help us do that? Broaden your skills. So, and this applies to anybody. I mean, I could have a different whole other list of skills here, but broaden your skills. Think of it as fun. Don't think of it as a chore. There's always some more to learn. And, you know, I'm not an expert at most of these, but you can learn something about a lot of them, and they can be very useful. So I'm not really an informatics guy, but I know enough to know what's possible and what's not possible usually. I'm not an EMR guy. I worked around order sets and written enough order sets and know how they work well enough that I know I don't engage in the magical thinking, you know, oh, EMR will fix that. But I know what it's capable of and what's not capable of, so I can work with the experts more fluently. So, and one skill often builds on another. So it's always good to be on the lookout for what you think will be powerful. Now, I did research, and I published probably 60 or 70 papers in the literature, but very much my balance is more on the QI side of research. So I found ways to get research dollars to do operational improvement, and I think that's not done enough. I think we could do a lot better at that at UC Davis Health, and I think most places could do a lot better at this. They tend to think about these as being oppositional, like, well, I'm not going to spend that money on research. You know, I can't spend operational dollars on research. Well, guess what? The research is fueling better operations. So I think we can do better at that. Engage in mentor-mentee relations. So this is probably the best part of my career. Sometimes you get a bad mentee. I won't mention any names, but sometimes most people in medicine want to do really well. They work hard, they're smart, they want to do things better, they just want to learn how to do it more efficiently. And if you can guide them through some of these things and set up some structure around it, it can be very helpful to them, and it can be very helpful to you. And I started mentoring residents and interns as I was a faculty member on a training program, but I've mentored far more non-residents and non-intern, non-house staff, in other words, people who are more advanced in their career, than I have others. And I think don't underestimate your ability to be a good mentor. You can be a really good mentor. You can avoid some pitfalls. One of the first rules is you never work harder than your mentee on their projects, right? And you should set up some expectations and make sure you're the right match before you enter that relationship. You have to understand, am I really going to help them get to where they want to go? Am I the right person for them or not? And then another tip, participate in community, just like you are right now. So this networking, I'm a big believer in it. I mean, a lot of mine came through professional societies and other venues, these quality improvement collaboratives. But some of the best friends I've made in my life, I made through those associations, and I'm still friends with them. We still correspond regularly, and they're in different cities with different lives, but we have common issues that we help each other with, and it's a great experience, and it's a safe place to gripe and be inspired, right? All right, my mistakes. What are my mistakes? Like I said, this might take a few slides. So tribalism. So as a hospice leader, everybody wants the hospice to do something for them. Everybody wants them to take care of ortho, take care of onc. Ortho is always like, oh, I'm just a carpenter. Pen, I can't write that thing. I had orthopedics tell me, wow, I don't want to take care of some patients. So, and working with, as we were at UC San Diego, when I started there, every hospice was on a teaching service. By the time I left, probably about only a third of the hospice, or maybe half, were on teaching services because our service far outstripped the residency program. So that was a big shift. And it was easy to be protective and say, no, we can't do that. We're here to be teachers. That was wrong. That didn't serve the patients. So we had to serve the patients. But anyway, I had to learn that you can't sit in a room and talk about those other guys. You have to get those other guys in the room. They're real people. They're usually well-intentioned. They're usually not evil. They're trying to get through their day just like you're trying to get through yours. And Dr. Moore, I give him a lot of credit. He's good at this with conflicts with his group, and sometimes leads his group where they don't want to go because it's better for the patient population. Oh yeah, I've done that. Fair warning. Don't do that. It's not productive. It's easy to get in a situation where you're heated, where you're protecting your turf, where you're protecting your guys and stuff. But that's not going to be productive. And remember, 90% of administrative leaders are actually 10% are evil zombie robots. But like I said, if you know the right person, they'll steer you around those people, and you'll be okay. Don't use email to resolve conflict, and if you're a young whippersnapper, don't use those things either. We have, at a very high level, great examples of how Twitter does not lead to good civil discourse. And again, if you really have this as a core belief, you have competing core beliefs. You want to protect your team, but you want to put patients first. And when push comes to shove, first is first, right? And that's hard to remember sometimes when your hospitalist are tired or when your team is tired. But if you frame it that way for everybody, most times the healthcare providers come together and come up with the best solution. And it will serve you well in the long run. Know when it's time to move on. So you can grow in an environment. Almost every healthcare environment, well, I'll put it this way, every healthcare environment is imperfect. You'll never find one that's perfect. And in fact, you don't want one that's too perfect because it's fun to change things for the better and see it transform, right? But sometimes you might find out it's just not in the cards. So I didn't leave Good Sam in Phoenix because I was unhappy with my colleagues. It was great. Dr. Cheney knew me then. I was, I thought I was well respected. I was having fun. But the truth was, I didn't see a career path forward because the guy above me was young and refused to die. So, and I had an opportunity to grow an academic center, to grow a whole new program in, the way I wanted to grow it. So that was a big lure. Don't forget this. Make time for yourself, friends, family, and I think self-reflection. Self-reflection is part of wellness. Self-reflection is part of self-awareness. I didn't talk about this much, but I learned a lot of things that I didn't do well, or things that made me uncomfortable in the workplace. Conflict, speaking with the surgeon, certain administrative leaders would give me the chills. But most time, faced that and got in the room with them, it was fine. Most time, if you had these direct discussions, it was fine. And if you're a faculty member on a service and your residents are complaining about somebody, don't make them, I mean, first of all, you should tell them the same lessons I'm telling you. It's better to have a direct conversation, not even on the phone, face to face, if you can do it. A phone call is much better than fighting through a note, a chart, or email, or text, or pages that are snitty, or an incident report that is just complaining about somebody. It's much better to have a dialogue. Sometimes using those structured tools I was talking about. Foster your sense of humor. A little exercise can help a lot. If you're working too much and you're not exercising, you're going to feel blobby. Trust me. It doesn't have to be a huge amount. A little exercise helps. And choose your life partner carefully, which I have. So I think those are some good lessons. I hope you take something useful away from it. One thing I did want to talk additionally about is this wellness piece, because we have, again, a new piece of infrastructure, Office of Wellness here at UC Davis, with a great leader, Peter Yellow-Lees. And people will misunderstand burnout and the approach to it, I think. So burnout is some self-awareness, and it is yoga and stretching and getting some exercise, right? It is all those things. But that's this much of it. The bigger part of wellness is making the system work for your staff, giving them a break, making the EMR more efficient, creating health, offering childcare, giving them a better place to park, giving them a pat on the back for a job well done, giving them the tools they need to do their job. That's the 80% of wellness. The rest is resilience and building up personal resilience. But if you're living in a shit system, your resilience wears out, right? You've got to pay attention to the system and make that better. So I think we're attempting to do that here. We're taking it very seriously. They just doubled, they're about to double the size of what we call the PEP team. That's a provider efficiency program, where they're going out to individual clinics, and now they're going to start tackling inpatient sites with just a series of tips and tricks and designer built right into the PEP team to change the EMR to work better for the frontline providers. So that's going to have, I think, 9 people on that team in a short amount of time. There's 5 in it now. You're going to go to 9 over the next few months. So that's just an example of the wellness piece. So I welcome your questions or comments. I don't have any other prepared comments, but thanks for your attention.
Yeah, I have a question. Great presentation, by the way. Really wonderful advice. You mentioned political landmines. I'm just wondering, have you ever hit a political landmine?
Oh yeah.
Give us an example of it.
Sure, this is a big lesson. So probably the first major political landmine I hit was I was fairly new at UC San Diego, and I saw a need for a quality improvement program, I thought, and I just started pulling together people to do it. There were other people who were doing it already who were hooked into a committee. So I was arrested for doing quality improvement without a license. And for sure, their efforts were inadequate, or I wouldn't have identified it as a problem, which was another inherent part of the issue that I stepped on, is that I was making some people look bad by bringing up data that said, this really sucks here, right? But we were able to get past that and join forces and make good efforts on it. In fact, that was VTE prevention, which I'm now kind of nationally and internationally famous board in some circles. So we had a patient who did poorly on our hospital service and had a PE, and they were not on the right prophylaxis. And I decided I was going to tackle that. And it was before I ever wrote for any grant. I started collecting data on prophylaxis, and we came up with a protocol about what adequate prophylaxis was and what it wasn't for these different groups of patients. So I started collecting data on that. And then I started looking at the number of DVT and PE in the hospital, and I didn't rely on administrative coding data. I was looking every day at the feeds from our radiology imaging systems. So I had very high quality data. And we would go and look at if the case was hospital acquired and if it was preventable or not. And I collected about 2 months worth of data, and I presented it somewhere, and then all hell broke loose. It was like, because some of these cases were on a service of somebody else who considered themselves to be a VTE prevention expert. And so I stepped on that landmine. But again, we worked through that, and we eventually got HRQ grants and built improvement guides. And we've reduced hospital-associated VTE at this system across the whole system by about 25%. We've done the same again across the entire Dignity system. Both those data have been published. So, you know, step on a landmine, brush yourself off, and go again.
I sort of feel like that's like what sepsis is now.
It can be, yeah, that's right. Although I think we've neutralized all those landmines with the Lebarsky effect. So we have a new vice chancellor, and he said to the chairs, "You will do this." And they said, "Okay." So far, so good. Good for us. Good for our team.
I think we kind of needed that, though.
We did. Other issues or questions? Yes.
How do you implement change when you have influential team members that are completely resistant to change? Because we know that there's a lot of people that are resistant to change, and so I'm wondering if you have any tips or tricks or tools that can help get out of that.
Well, team rules is one thing. So when you start an improvement effort, it helps to have sort of, this is how we're going to go about our business. And, you know, once the team reaches decisions, you don't talk bad about it at the water cooler, right? Where we move forward. But probably most importantly, you have the right people on your team. And if you've got somebody who's really that resistant to change, they probably don't belong on the team because they're not recognizing the need for change. Now, sometimes they might resist a change because they see an impact that will be adverse in some way you're not thinking about. That's a whole different matter. That's a good thing. That's a good thing to get that input. But somebody who's just flat out resistant to change should not be on an implementation team, because what's the point of an implementation team if it's not to change things? So, now, you might be in a situation where that team member who's really resistant is on a higher place in a power hierarchy than you are. That's trickier business, right? I don't face that as much as I used to. Still face it sometimes. But you know, it helps to have friends in high places. And again, this culture, the expected culture is people work together professionally to get things done, right? That's part of the charter. If they're not meeting that mandate, then someone from above you, perhaps, can message to that person. A lot of people have team rules posted, and they'll just point to the team rule if they think somebody's out of order. Brent James is always teaching that at the Intermountain Health, right?
And I think data plays
Is huge, right? Exactly. Just a little data can change people's minds.
So if you're working in teams, I mean, I'm trying to do more continuing education and Scrum and Agile strategies. And part of that is when you are in a team that's trying to accomplish something, removing titles. And I said, maybe it's easier said than done, but making sure that people don't feel that because somebody is in the hierarchy above them, that it's not an okay or safe place to say something. And so to neutralize
Absolutely.
that, right, and be able to still contribute and be able to move the team effort forward. And so maybe just gaining agreement around that when you get started.
My earlier approach with threats of violence didn't always work out.
He still uses them.
A couple things. One, I so appreciate you giving me the title of doctor, but I never went to medical school.
Oh, excuse me.
But I appreciate that. I played one in high school, but not a physician. Two, if I were going to change your presentation, I would change it to, instead of how to be lucky, I would say leadership matters. Because I know you, and luck had nothing to do with why you're here today. We miss this guy in Phoenix. And he went, as an administrator, I couldn't stand him because he led with passion around patients, and I love that, but he always came with data. He was a data-driven guy. And as administrator, especially a young administrator, I thought I knew it all. I didn't need data, just follow me and I'll tell you. But he was right, obviously. So I appreciate you're so humble. You haven't changed. But it's leadership. Your leadership is what makes a difference.
Thank you. Can't top that, so. Session over. Drop the mic.
Sometimes, in a position of leadership, you feel like you're herding cats. It's really hard to get people to do things, or come to the committee meeting. I can't get, very difficult to get people in that group. How do you, how do you get people engaged? We show them data, and it just seems to gloss over. We have incentive performance, packages that just sort of, also doesn't really seem to make that much of an impact. So how do you get people engaged in the room? How do you get them excited, involved?
Like that earlier comment about threats of violence. But it's complicated. I mean, no one solution works for everybody. Data helps for some, making their job easier in other ways, and saying, if you do this, trying to couch it in terms of both, it'll make the patient's life better, it'll make your life better. If you can find ways to, show them that will, in the long run, help their efficiency or their work, at the same time help the patients. But I don't have any secret answers. I have to say, I'm trying to support the medical staff, but I've been supremely supported by Dr. Kirk, our CMO. And often when it comes down to it, from the CEO, Ann Rice before, and now with Brad Simmons, and a lot of people didn't think Mrs. Rice was super warm and fuzzy. She wasn't. But she doled out the dollars when we showed her the data and the need for it. And that's to her credit. So now she's gone somewhere else. But so the support has been there from us. And I think fundamentally people just have to believe that change is possible and that you want to help them affect that change, and that they should want that change too. And that I'd much rather be the changer than the changee. I'm always trying to frame it to doctors that, I want to do things for them, not to them. I want to help them do their job better. I don't want to make them do a best practice. I want to help them do things better. So framing can be part of it. And there are, frankly, I think there's 20% of people or so in healthcare, maybe higher, who will always do a really good job and be engaged almost no matter what you throw at them. There's people on the other end of the spectrum who you just can't engage. And maybe they're on the wrong team. Maybe they're having a problem. Maybe they have a wellness issue. Maybe they have depression. Think about those things, about if you're not having success with somebody who's just not functioning like they ought to be. But a lot of people are in that middle ground where if you give them the tools, they'll engage. And, I guess you engage the people you can and look for the leaders where you can and get them engaged. And, you're not going to engage everybody, but you don't really need to engage everybody. You just have to convince them to get out of the damn way. So they don't have to lead the change, but they can't be change resistors to the point where they nuke your attempts to standardize something. That is an unacceptable practice. They can inform your standardization practice, and they can inform how you might improve it, but they can't say we're not going to standardize around an important issue.
If I could just add from my perspective, when I first met you, I think I was kind of voluntold that there was this project that I needed to work on over at the Sherman building, which is the great fear of any clinician to go over to the Sherman building and all the admin and meet with Dr. Maynard. Never heard of you before. But when I met you, you seemed to be able to kind of just project your vision. And being a member that was on that mislabeled relabeling project.
Right.
Lab specimens, we're trying to reduce mislabeled and unlabeled lab specimens and make our results accurate. Going after the little minutia that had significant impact, right?
Right.
But you.
With the mislabeled ones being the most dangerous.
Yeah.
Right.
Yeah. But what I remember from that project that was really refreshing, and I think why we've made some good headway there, is that you let us do what we needed to do. You knocked down the resistors in our way anytime we've mentioned your name. And I don't know if you were doing anything purposeful behind the scenes here for us or not, but anytime I got a hold of you,
It's amazing
problem
how
on the
little I
way.
have to do. It's amazing how little I have to do.
But,
What I mean by that is the resistance is usually false. The
Yeah.
resistance is usually pseudo-resistance. It's usually, look, we really need to do this. Here's a safety issue. I'm pulling a safety card. Here's an example. Somebody got hurt by it. So we have to do this. Okay. It's like, I'm not fighting big fights most of the time.
Yeah.
I'm just nudging things along.
But it was easy because you expected me to do something, and you let me have the tools to do it, and we did it. And it was really, really easy working with you. And that was the amazing part is that you are so easy to work with. But I think you work really hard behind the scenes, and that's the lucky part, though. The harder you work, the luckier you get, right? But that's just from my perspective, working with you on that one project, is that you kind of just got out of our way, let us do our stuff, clear our path, and give us the tools.
Yeah, that is the job description of a CQO right there. Give people the tools and get out of the damn way. All right? That's what I'm trying to say.
So just after kind of working with you for the last 6 or 7 months, something that I've learned since coming into my role is when I first started, I was maybe kind of almost had an intimidation factor by going into so many different committees and thinking like, how am I going to learn like all the workflows and kind of work with all these subject matter experts and know what they know? Well, the answer to that is you're never going to be the expert on that. And I think kind of the go off the coattails of what Lynn was just saying is we don't have to be the experts in the room, and just kind of leading them in the direction where they need to go and just kind of setting the table for them to do the work, just pointing them in that direction, just kind of nudging them in the direction they need to go is something that's really all they need. I think that's kind of giving me more confidence in that arena to just be more of a facilitator and pushing people in the right direction, asking the right questions. It's something I've seen you do, and I've learned a lot from you so far.
Thank you. Eddie, I'd like to hear from your perspective. Eddie is the most popular guy. They worship him because he is a good project manager that works with us, and he helps give them a little bit of structure. Just tell them a little bit about how you work with these groups and what you found about working with them.
Yeah, I think from my experience, and like me to say, how you handle the resistance, and the way I found that the best way to handle is in 3 things. One is you build a relationship with the clinician.
Right.
You build that trust, and also you respect some of the work they have done, and instead of just like I said, you're not changing the people, but you're helping them facilitate and be part of the change. And I mean, for me, it's been a great opportunity to work in different areas: the sepsis, the transfusion, the fan of building that relationship, and it also helps to have that community on your back, and then you can always that name whenever it's needed.
I do that as well.
Always works.
It works.
I think I have a really good job because it's endlessly interesting. You go and work with people who are incredibly talented and hardworking across a huge spectrum of care. I mean, we were in the meeting the other day with case managers and social workers talking about transitions, and the next minute we're talking about, you know, the transplant program, and the next minute you're talking about something entirely different. And we put together these hub meetings where we sit in this room actually and bring in, instead of sitting in a big committee, we bring in these individual groups and we ask them to provide us with their sort of their quality and safety and efficiency data against benchmark whatever possible, and walk through their barriers and their things they're doing well, things they're having problems with. And we're not there to grade them, we're there to help them, right? And they're starting to get that we're not there to beat them up, we're there to help them. It's like, you know, we're the government, we're here to help. You know, they don't believe that sometimes, first time. But anything else? All right, thank you guys so much, appreciate it.